Great. Good morning, everyone. Welcome to our June AIDS Clinical Conference. I'm delighted to introduce our speaker today, who's going to be speaking about HIV and older individuals. Dr. Green is an associate professor in the Department of Medicine in the Division of Geriatrics at University of California, San Francisco. She's board certified in internal medicine and geriatrics, and part of as an AA/HIVM specialist. She is interested in the intersection of HIV and geriatric medicine and striving to improve care in older individuals with HIV, and we have that growing population of those individuals. She's also the associate director of the Geriatric HIV Consultation Clinic at the Zuckerberg San Francisco General Hospital, where she provides weekly geriatric consultation. She received her MD from Wayne State School of Medicine and completed her internal medicine training at UCSF, and as well as her geriatrics fellowship. So it's my pleasure to introduce her today and learn from her. Thank you, Dr. Green, for joining us.
Great, thank you so much. So we are going to be talking about HIV and older adults. And just disclosures. And I'm going to go through the other slides here as a reminder. So what are we going to cover today in this hour? So we're going to talk about some of the common medical and social challenges facing older people with HIV. And then we're going to, throughout as we're doing that, describe some of the key aspects of geriatric assessment or geriatric principles. And we're going to do that using the 5 M's framework to kind of better describe what geriatrics can bring to the care of people with HIV. And the 5 M's, so that you'll remember for later, is multi-complexity, mind, medications, mobility, and matters most. And throughout, we're going to talk about ways you can do this in your own clinical practice. So I wanted to start with, there will be a couple short cases. This is actually a 74-year-old man who was diagnosed with HIV in 1984, long-term survivor. And he was a patient at our local VA clinic. At the time, he had a CD4 count in the 400s. He'd had an undetectable viral load for many years. But he had many other chronic conditions, including hypertension, chronic kidney disease, osteoporosis. He'd also been treated for anal squamous cell carcinoma and gone through chemo and radiation, had a history of depression, was taking more than 9 medications a day. And, when he was interviewed at the time, he said, well, I quit my job when I was diagnosed. So he hadn't really saved for retirement, and he reported that he had lost a lot of his social network in the 80s and 90s living in San Francisco during the height of the AIDS epidemic there. And what he said when he was interviewed for the series was, when you got HIV in those days, it was a death sentence. That was what you expected, that you would die, and to live even 5 years was a surprise to me. And here he was at the time in 2013, 30 years later, being interviewed. He is certainly not alone. Now, the data in this slide from the CDC are 2018 data, so these numbers are now even higher. But even in 2018, in the United States, over half of people living with HIV or diagnosed with HIV were age 50 and older. And while most of those people were like Mr. H, who had aged with HIV, I think I just wanted to point out that new diagnoses do occur in older adults. And if you were, in fact, to stack up these bars on the right, which includes 50 and older, they would be higher than this 35 to 44 and approaching the 25 to 34. But I feel like we rarely hear about this in older adults. And like Mr. H, we know that HIV increases the risk of other chronic conditions. Some of this is through chronic inflammation, even when someone has an undetectable viral load. Some may be side effects of antiretroviral therapy, and others may be lifestyle things that contribute to chronic disease in everyone. And these conditions might include osteoporosis, certain types of cancer, especially virally mediated cancers, coronary artery disease, chronic kidney disease. And not only are people dealing with chronic conditions as they age, we also have to think about geriatric conditions or sometimes geriatric syndromes. And these are conditions that are actually multifactorial in nature. And this was a study we did early on in San Francisco at San Francisco General in the VA. And here in this group who had a median age of 57, all with well-controlled HIV, you can see that all these different geriatric conditions were very common. Falls being seen in 25%, having an abnormal cognitive screen in almost half, difficulty with one or more activities of daily living or instrumental activities of daily living, again, in almost half. So these are also very common. And so what we end up with is, if you think of Mr. H, really this increasing complexity in many of the patients we're seeing. And while HIV might not be the most pressing thing when you have an undetectable viral load and a reasonable CD4 count, it's really mediating everything else. So multiple chronic conditions, which you'll hear will lead to polypharmacy. And if you think of Mr. H and other long-term survivors, often there may be these unique economic issues as they were not planning to live or plan for retirement, and often unique social issues as well as mental health and cognitive problems can be common. And while these things I think are common, I feel like we are often still focusing on viral suppression. And I think in the care of older adults, we really need to think beyond this. And if you think of older adults as a whole, they tend to be doing better on the care cascade compared to younger individuals. And so I think this is why this has sometimes been neglected. But this is where the geriatrics approach can help. So the 5 M's of geriatrics is describing what the geriatricians or the field of geriatrics does. And multi-complexity, which I think is really, really relevant to HIV, is the first one. Mind, which can include cognition and mental health. Mobility, which includes functional status and falls, medications, which we will talk more about, and what matters most. So these are the 5 M's, and these are the things we're going to think about in what you can do to care for older people with HIV. And just to point out that these are starting to show up in some of the HIV clinical guidelines in the US. They've been present in Europe as well. Including here, the box from the IAS guidelines, which talks specifically about polypharmacy, mobility, and frailty. So multi-complexity is the first M we're going to talk about. And when I think about multi-complexity, it's these things. It's multi-morbidity and polypharmacy. Really, HIV is a model of multi-morbidity. And you can see here in this figure that multi-morbidity is higher in people living with HIV compared to their HIV negative counterparts. This just shows the black bars being 3 or more chronic conditions, higher in the group with HIV, and of course increases with increasing age. Geriatric syndromes, which I showed you earlier and which we'll talk more about, and also complex psychosocial situations. So thinking about multi-morbidity, so why is this an important distinction? So I think oftentimes we think about comorbidity, if you're an internist like me, you're trained to think about all the things on someone's problem list and how you're addressing them. But you really have to take a more holistic approach. If you try to think, if you look at individual disease and screening guidelines, they weren't really meant for people who have multiple chronic conditions. So they're really focused on someone who just has diabetes or someone who has COPD and how to treat that. But the reality is that treatments will interact and medications will interact, and that's often what ends up happening. So thinking of the person is living with all these things at one time, and you have to think of it from that lens. So why else is multimorbidity an important distinction is that it leads to polypharmacy. And in polypharmacy and HIV, just like multimorbidity, there are studies now that have shown that it is higher amongst people living with HIV. And, despite this, it does seem to older adults still tend to have higher rates of viral suppression, but I think there is some studies out there suggesting there may actually be less adherence to non-antiretroviral medications when there's multiple medications. And of course, the risk of drug-drug interactions increases with the more medications you're on. And there have been studies now looking at associations with falls and increased symptom burden with the more medications you take amongst people living with HIV. So I wanted to go through an example of how you could approach someone with multimorbidity and polypharmacy. So this is a routine visit, 68-year-old male, identifies as a long-term survivor, again, well-controlled HIV. So medications are here on the right. You can see he has high blood pressure, high cholesterol, neuropathy, diabetes, BPH, chronic kidney disease, insomnia. Yes, this is maybe a little bit of a simplification, but a routine visit, maybe you're reviewing labs and he mentions that he feels like he's taking so many pills. So how can you approach this? So the first thing is looking at if there's an indication for each medication. Is it appropriate for their renal and kidney function or liver function? Are there symptoms that can be related to medications? And we're going to go through these. This figure is actually from the European guidelines, and I'd encourage you to take a look, but this is essentially the steps they're going to go through. So if we're going to go through these steps, what would we do? And the first thing I also wanted to introduce was potentially inappropriate medications. So what are these? These are a list of medications to consider avoiding in older adults. Commonly in the US, you'll hear of the Beers criteria. The European version is the start-stop criteria. Both have been studied. Again, this is from the European guidelines and are examples of drugs to consider avoiding. Now, potential is there because there may be a really strong indication that someone needs a medication, but these are medications, for example, that tend to have more side effects as we age, including benzodiazepines or really strongly anticholinergic meds, certain antihistamines. And there are also lists of drugs that should be considered or might be contraindicated in certain chronic conditions. So there are things you can do for reducing potentially inappropriate medications. This was actually a study that was done in Canada and in Quebec. And what they did was it was a cluster randomized controlled trial of pharmacies in Quebec. So what they did was patients were randomized to just usual pharmacy visit, or they were given this brochure. This is a part of the brochure here. And that was it, very low touch. But at 6 months, a third had actually stopped their benzodiazepine compared with only 5% in the control or usual care group, and 11% had further reduced their dose. So this is a very simple thing, literally handing out a 6-page brochure, which was in large font and at a 6th grade reading level, and had a reduction in medication. So sometimes it actually is just giving people the information about the harms. But if we come back to our case, what would we do in going through those steps? So the first thing is you're going to confirm all the medications, and that includes over-the-counter, herbal supplements, also thinking about alcohol and other substance use and how that can cause interactions or how the body's going to process medications. And think about once you've got a confirmed list, in this case, in addition to all the medications we knew about here, he was also taking 4 vitamins and also over-the-counter naproxen. The second step after you confirm all the meds, is there an indication? And so here you can kind of look. So he has hypertension. So, okay, there's medications for that, hyperlipidemia, diabetes, insomnia. Okay, maybe that's what the zolpidem is for. Tamsulosin might be for his BPH and the fast ride. So overall, I would say yes, there does seem to be an indication. I know we don't have doses here, but with doses, you would look at, especially with someone with renal insufficiency, thinking about, are they on the correct dose? And this is especially important as people's age because renal function naturally declines with age. And then the other thing would be asking if there are any symptoms or if the patient is reporting symptoms, thinking about, is there medication that could be the cause of those symptoms? And often, for example, someone might be reporting leg swelling, and you can think about, is that caused by their amlodipine? And why this is important is because often what happens is this prescribing cascade. So let's say in this case, he is taking PRN naproxen. So maybe someone is taking a lot of NSAIDs not known at home. This actually can increase blood pressure, get started on amlodipine. That causes ankle swelling. That leads to a prescription of furosemide. That in turn leads to low potassium and results in potassium supplementation, which causes nausea, and you end up with an antiemetic. And while this seems like, oh, maybe a little far-fetched, or, oh yeah, it is really all too common. And sometimes it can be really hard to trace back why something was prescribed. And so that's why understanding the indication, and always before prescribing something else, pausing and saying, okay, is what I'm treating actually being caused by something else on this list? Next slide. So those are the first 3 steps. Once you've confirmed the medications, is there an indication? Is the dose appropriate? Trying to avoid the prescribing cascade by thinking about symptoms. And the next step is, are there any drug-drug interactions? And so in this case, you could say, all right, with the dolutegravir and the metformin, there's a potential interaction here. Of course, you can have a maximum of 1,000 of metformin. And then are there potentially inappropriate medications? In this case, on the beers and the start-stop list, zolpidem would definitely be there. Maybe gabapentin. Also, I meant to point out that with drug-drug interactions, you'd want to clarify what the vitamins are, thinking about calcium and other cations with dolutegravir. So maybe there's zolpidem as a potentially inappropriate medications. And are there other medication concerns? So this might be someone tells you they're struggling with adherence, asking, like, because sometimes you find out that they have a really high copay. Or is it just too complex a regimen? Like something has 3 times a day, but something else has to be taken on an empty stomach in the morning and something else right before bed. Sometimes it's just a lot. And so in this case, he said too many pills. So you might want to focus on how can we maybe reduce one of these medications. Many of you are probably familiar with the HIV drug interactions website from Liverpool. So again, just acknowledging drug-drug interactions and always thinking, of course, about vitamins and supplements, as well as inhaled and intranasal steroids. For additional resources, deprescribing.org is actually a Canadian website that is where you can actually search for those Empower trial brochures, download them, give them to your own patients. Also, set in the last 2 years, the US has started a deprescribing research network, which is really looking at the science and trying to strengthen the science behind deprescribing. And so if this is something you're interested in, it is open and you can visit their website as well. So I wanted to switch from medications for a minute. We're going to come back to our case, thinking about how we can reduce pills and talk about the other M's. So the next M is mind. And often we'll think about cognition. And just to point out, with HIV, we know that although the severity of HIV dementia has declined, we're seeing milder forms. It seems like the overall prevalence actually has not really changed since the 80s and 90s. And if you think classically of HIV-associated neurocognitive disorders, the symptoms are really focused on executive function, which you can get at by asking about multitasking, planning, organizing, attention, which is often really perceived as having trouble with memory. It's more people can't concentrate or focus to remember. There can be slowing, psychomotor slowing, and motor symptoms, and in general tends to have more of a fluctuating course, not a steady decline like in Alzheimer's disease. And I put in comparison this figure from the Alzheimer's Association, which talks about what is a sign of Alzheimer's versus a typical age-related change, because I think you actually have to first understand, well, what are the normal changes with memory as we age? And it is normal to every once in a while miss a monthly payment, for example. But what is a more concerning sign is someone who has always been managing the finances is now struggling to do that or to manage a budget. And also really to think about cognition and cognitive impairment as a geriatric syndrome, so multifactorial, so many contributing factors. It could be from HIV, it could be from other comorbidities. Medications can contribute, things like, and other comorbidities, thinking of things like sleep apnea and substance use. And I think really important to point out that when there is active substance use, you're not going to be able to distinguish what is the etiology of their cognitive symptoms. So how can you actually assess for this in clinic? The mini cog is the fastest, which is a 3-item recall and a clock draw. May not be the most sensitive, but if you really needed to do something and you just have a minute, you could do that. MMSE is what I learned in medical school. It's actually now copyrighted and actually not probably the best for people with HIV because it's not as sensitive and doesn't cover a lot of the domains affected by hand. MoCA is probably the best that we have in short tools that I think you could realistically do in clinic. It takes 8 to 10 minutes and has been validated in hand. The HIV dementia scale, there are, of course, older HIV specific forms. These are now good at detecting the severe cases of HIV dementia, but they're really not sensitive now for the forms of hand that we're seeing. And so actually the MoCA has better sensitivity than some of the dedicated HIV scales. And there are an array now of digital assessments being done that are also being validated in people with HIV, and a lot of ongoing research into this. So what can you do when someone comes in, you do a MoCA, maybe you have some concerns? What are some of the things to be thinking through? So one, CSF escape is rare. We hear a lot about it, but where I can think about it is if someone is having really new, rapidly progressing cognitive symptoms, usually they will also have an abnormal neuro exam. That's when I get an MRI and think about doing an LP. If someone is not on ART, of course, that is still the mainstay treatment of hand. And sometimes we'll see people who are struggling with adherence or who came off meds, develop cognitive symptoms. And I usually say you need to give it 6 months to a year to really see how things are going to settle out. addressing polypharmacy and reducing medications that can exacerbate cognitive symptoms, especially anticholinergic meds. Treating comorbidities, vascular risk factors are really important. Thinking about the overlap with depressive symptoms, sleep, because sleep apnea and other sleep disorders can contribute to deficits in concentration, sensory impairment. And then, so if you address all of those things, what are some of the things you can do aside from making sure someone's adherent to ART? There have been small studies looking at exercise in people with HIV. We know that exercise is one of the main things to help prevent Alzheimer's disease. And then coming up with compensatory strategies, often with hand executive functioning. So having someone using a list, using calendars, focusing on one task at a time and avoiding multitasking can actually be very effective strategies in managing some of the symptoms. And then, of course, always thinking about advanced care planning. Not everyone is going to progress to HIV dementia, but it is always important to make sure that can you help someone identify a surrogate decision maker if they were to become incapacitated? Not just important for people with cognitive impairment, but for anyone. And also mind, in addition to cognition or memory, is also mental health. And I think we hear a lot about depression in people with HIV, but just to point out, it's not just depression, especially for long-term survivors. If you think of Mr. H, or in our second case, there's often traumatic loss and maybe complicated grief. There is stigma that people are dealing with, not just from HIV, but they may be dealing with homophobia or transphobia or racism. And now they're also maybe dealing with ageism. Many people have a history of trauma. And even as we talk about adverse childhood experiences, I see people in their late 70s who are still struggling to come to terms with that. And so I think we have to think about it even in our older adults. And then, of course, substance use disorders and all of these things can easily become intertwined. So we've talked about multi-complexity, medications as part of that. Mind and geriatric syndromes, again, as part of that complexity. Want to go into our next mobility. And one of the simplest ways just to ask about mobility and functional status is just to simply ask, are you having difficulty with these tasks? Asking about ADLs, which are things like getting dressed, getting out of chairs, taking a shower, and IADL. So this was what's more common deficit and probably what you'll see more of in clinic, because if you have 2 or more dependencies in an ADL, this is someone who needs 24-hour care and either will be living at home with a full-time caregiver or in a long-term care setting. So in your clinic, you're most likely going to see people who are starting to have trouble with instrumental activities of daily living, like taking your medications, cleaning, getting out to appointments, managing finances. So you can simply ask if there's difficulty with that task, or if someone is having to help them do it, or if they need help. And then mobility, you can ask about stairs, and you can just ask, how far can you walk before you feel like you need to take a break? And that can give you a lot of information about how someone is actually getting around. There are other objective tests you can do. This is the short physical performance battery, which is 3 balance tests, a gait speed, and a chair stand test where you get up as fast as you can 5 times from the chair. So these are things you can reasonably do in clinic if you have the space for a gait course. If not, you can just watch someone get up from the chair in the exam room and walk down the hall, or as they're leaving your room, you can watch how they walk and watch how they get up from the chair. The SPPB I highlighted here because it has been shown to predict 5-year mortality in people with HIV. In this study, actually with a group of current and former injection drug users in Baltimore, the HIV positive group with abnormal physical performance had the highest 5-year mortality rate compared to the HIV negative group who had normal physical performance. And this was in a group who had a mean age of 51. And these were tests originally designed for people in their 70s and 80s. But we're seeing here even in people who are younger, these tests can still have predictive value. So something as simple as watching someone get up from a chair and walk can tell you a lot about their day-to-day function and has significance. So another big part of mobility is asking about falls. And I think this is really important for people living with HIV because of the increased risk of osteopenia, osteoporosis, other bone health concerns. So I like the CDC study because it has a wealth of other resources there that you can look at. It's 3 questions. Do you feel unsteady when standing or walking? Do you worry about falling? And have you fallen in the past year? You could also just simply ask, have you fallen in the past year? That takes 30 seconds. So can easily be incorporated into say while someone's getting their blood pressure taken. And then depending on whether they screen positive or not is going to determine your steps. If not, you can give them some education and move on. And if they are positive, then you can go into more depth to address. So I want to come back to our second case, who we talked about multimorbidity polypharmacy, was coming in for a routine visit, concerned about the number of pills. So now I'm going to give you some more information. So we ask about functional status, independent with all ADLs, is unsurprisingly maybe having some difficulty managing medications, maybe because feels there's too many pills to keep track of, and also mentioned having some trouble keeping up with house cleaning, maybe a little because of the swelling in the legs and some back pain. You also did a MOCA, a normal score 28 out of 30, and he's not reporting symptoms. So you move on from that and you ask about falls. No falls in the past year, but yes, feels unsteady when standing or walking, not worried about falling. So this would actually be a positive screen because he answered yes to one of those 3 questions. And that's what triggers the positive screen. As I mentioned, falls are common in people with HIV, not necessarily more common than people without HIV. If you look at the studies in like Max and Wise, where they've had control groups. But if you look across the board at a lot of these different cohorts, you'll see relatively younger ages. I mean, 20 to 40% frequency of falls. So something we should be asking about. So what happens now in our case? So he says he feels unsteady. What does that actually mean? So it turns out he feels dizzy when he gets up out of a chair. And again, if we think about his medications, what could be causing that? So he's on 2 antihypertensives. He's on tamsulosin for his prostate. And also we know zolpidem can have some adverse effects as well. He reports some changes in vision. You can simply ask, or if you have a Snellen chart in your clinic, you can use that. You ask about home safety. These are the steps here that you would go in more depth. And it sounds like he doesn't have loose rugs on the floor, has lighting. He has not yet had a DEXA to assess his bone health, but again, you want to make sure you're thinking about that as well. So on his exam, he was actually orthostatic, and you notice as well, he has some decreased sensation in his feet. He does have that history of neuropathy. He was taking gabapentin, but he's wearing good footwear, which is actually important. And when you test his balance, you're doing the SPPB maneuvers, he has difficulty with one of the balance tests. So does seem to have some balance difficulties. So then what is your plan here? So the plan actually relates back to all his initial plans as well. So he's orthostatic, so we need to address that right away. He's symptomatic. So in this case, his amlodipine was stopped. He was given a home blood pressure cuff to monitor his blood pressure. Also, his tamsulosin was switched to nighttime to see if that helped, so he wasn't taking both the lisinopril and tamsulosin in the day. Could talk about alternatives to zolpidem. And because of the balance difficulties on exam, could consider referral to physical therapy or show him some other exercises, give him handouts to support his balance. And also he mentioned the low vision, so thinking about referring to an eye exam. And again, all of this is from the CDC study website. You can download pocket cards, you can get things on your phone. So you don't have to have this all in your head. You can look through and come up with a plan. So those are things you might not do all at once, right? So what happens in this case? So again, coming back to all of it, including the medications, he wanted to actually reduce his pills. Because of the concerns about the naproxen, he already had some renal insufficiency as well as his blood pressure, willing to stop that, try, Tylenol or something else for the occasional back pain. Also stop the amlodipine. Blood pressure did okay without it. And he was thinking about doing a zolpidem taper. He reported some difficulties with managing his medications. So he actually was connected with adherence packaging by one of our clinic pharmacists to support his adherence. And we were able to get him in-home supportive services who were coming at least once a week initially to help with some of the housekeeping tasks he was struggling with. The fall risk, again, many of these things travel together, and one thing can actually help multiple things, a simple intervention like stopping a medication. So his dizziness resolved after the amlodipine was stopped. He went to ophthalmology and he got new glasses. And down the road, he did have a DEXA scan that had normal results. So again, his symptoms were improved. He was taking less pills, which was what was important to him. So also you can see how this can help with someone's overall quality of life and function. So I want to come to our last M, which is maybe the most important actually, which is matters most and can be thinking of in the context of advanced care planning, not just in thinking about code status, but thinking about prioritizing multimorbidity. What is the priorities for the person in front of you? And you're not going to be able to address everything at once. So what are their priorities and what can you do? I did want to take some time today about thinking about loneliness and isolation, which came up in the case of Mr. H. And I think especially with after COVID. So what is loneliness? Loneliness is the subjective feeling of being alone. Social isolation relates to the number of relationships. So it's not the same as living alone. You can be living alone and not feel lonely. You could be surrounded by people and feel incredible lonely. So loneliness, subjective, social isolation referring to actual numbers of relationships. And why is this important? We know the Surgeon General now has a campaign about loneliness. The UK has had one for many years. This is important because it has been shown that it affects depression and mental health, cognitive and functional decline, and increased mortality, similar to smoking 15 cigarettes a day. So how could you approach this? So some people would just flat out ask, do you feel lonely? There's some controversy over this. Is that stigmatizing or is it less stigmatizing to just be direct? You can instead of that, you can do something like the 3-item loneliness scale. These are the 3 questions. And when you add up the points, then you can determine that. Ask about social support. How many people do you feel you can depend on or feel close to? In my clinic, there's a lot of times people can't even identify an emergency contact. And so this is at least opening the conversation. And I think normalizing that they are not the only person. I think related to this is also asking about telehealth capabilities, because so many things had switched to online platforms, and that was a way for people to stay engaged. But if you weren't able to do that, you were still excluded. And if you think of the digital divide, and often really asking about an emergency contact can lead to larger discussions. I use this all the time to then ask about surrogate decision makers, and starting to think about steps in advanced care planning. So in HIV, there have been actually a few studies looking at interventions for loneliness. These are not necessarily specific to older adults, but there have been examples of online support groups, mindfulness-based cognitive therapy, a telephone-based intervention, And even interventions that were not focused on decreasing loneliness, but were focused on smoking cessation or sexual risk behaviors, that group interaction decreased loneliness. And I think these are not things you're going to necessarily do yourself, but thinking about what are the services in your area, partnering with community organizations, I think is really critical. What are the things you can do? And of course, also thinking about sometimes the most lonely or the hardest to reach. And also, I think recognizing the resilience of our patients, because so many have overcome so much just to be there in the room with you, and acknowledging and recognizing this, because I think a lot of times this all gets kind of framed as like doom and gloom around aging. And again, I brought this up because I think the isolation and loneliness are so important as we're now at the end of the public health emergency. But of course, saw so much isolation, especially in the early days of COVID. And I think we're really just starting to see the real what the mental health consequences are. I had a lot of patients who increased their substance use or relapsed over the last couple years. Very early on, some people were so afraid of leaving their homes that they really had functional decline. And also still a challenge if we think about all the changes in workforce that have happened over the last few years. People are struggling to have consistent caregivers. And this is something where we really need to advocate for the people providing that direct care who are in very low paid jobs, doing an often very difficult tasks. During COVID, or even as we continue with telehealth, I am still using telehealth in some roles. I think it can actually improve access for some of our patients as long as we can address the digital divide. And many things you can do, asking about falls function, that can even be done on the phone. If you have a video connection, you can still observe gait or watching someone get out of a chair. And there are actually advantages. Some of this is you can actually see part of their environment. If you want to do a med review, have someone bring in all their bottles. And why I think there is still a critical role for this is it actually improves access for people with limited mobility, or the person who has to take 3 buses to get across town. And so while I don't think it should replace all in-person care, I really think we need to think about how this can actually help for people who have multiple chronic conditions and a lot of appointments as well. Now, and we've talked about a lot, and I want to make sure we have time for questions. And I know you're like, okay, this is great, but like, how? I don't have a geriatrician in my clinic. How am I practically gonna do some of these things? And this is where we really have to think about a team-based approach. And even if you're a solo practitioner, what are your local resources? Is there one pharmacy that most of your patient gets their medications? And can you like reach out to that pharmacy? What are the community organizations in your area? Are there telehealth options with other geriatrics providers in your area? Thinking about like ECHO model, for example. Which areas, because you're probably already doing some of the 5 M's, are you already addressing? And just pick one. Maybe you're already screening for depression, so you're going to focus on mind and mental health. And what is the staffing in your clinic and the availability to help with doing assessments? This cannot all fall onto one person. If you are the only person, then you're going to space it out over visits. And maybe there's phone calls in between, or maybe you can have people fill out forms depending on their literacy levels. But you're going to break it out over time, or you have other staff in your office who can ask about falls or do a PHQ 2 or 9 for depression. Because the main thing is it's not just asking the questions as you saw with falls. That doesn't take a lot of time, but you need to make sure you have the follow-up after you ask the questions, because really geriatric assessment is not just assessment, it's a treatment plan. And so the 5 M's helps you to think of the areas you're going to assess, but you have to make sure you have someone who can help you follow through on after the screening and assessment. And as I said, just I think a team approach is really helpful, but you can break this into multiple visits. And again, just to emphasize that you hear a lot about it takes a village to raise a child. It really takes a village to support someone who's living with multiple chronic illnesses and is older. It also really takes policy, again, not just falling on individual clinicians. And that is one thing that has been a positive development in the last few years. Grant Makers and Aging group of aging philanthropists, and then HRSA came out with their white papers, and then the SPINS project, which is focused on HIV and aging, that is now underway in the past year. Also at the federal level, moving beyond the cascade and thinking about quality of life and the national HIV/AIDS strategy, which is going to include many of these components that we talked about today: mental health, self-rated health, nutrition and food insecurity, employment and housing. And these are starting to be reported out on. So that we have time for some questions. So we talked about the 5 M's today of geriatrics and how you can use that to think about addressing this multi-complexity that many older people with HIV are experiencing. So for mobility, you can ask about daily activities. You can ask about falls. You can consider doing an objective assessment like the short physical performance battery, or just watching someone get out of the chair. The CDC study has all the resources on their website, including how you can do some of the tests like a timed up and go. Mind. So how can you assess mental health and cognition? We talked about the MoCA is probably the best clinic-based tool for hand. And then matters most. Here today, we talked about loneliness and social isolation and just normalizing it. And if you want to use a short assessment tool, the 3-item loneliness scale is probably the most practical for busy clinical settings. So with that, just some acknowledgements of all the people I work with to do our geriatric HIV program. And now we have some time for questions. So thank you.
Thank you so much, Dr. Green. That was an excellent and very practical talk, and I really appreciated your practical advice at the end about how to incorporate all this, because I agree, it does seem overwhelming to try to do this at each of the visits. And I'm wondering, at your clinic, I mean, you're present at that clinic, but do you have a way that you just screen all the patients above a certain age, and even between visits, try to do some of these things with some of the multidisciplinary team, like social work or any contact point that the patient has, even with pharmacy, so that there's, a flag to kind of bring up these issues or evaluate some of the issues that you're talking about?
Yeah, great question. And we've gone through various etiologies, and of course, COVID, shifted. So pre-COVID, we were the nurses were doing screenings of all our patients. I think, again, it's what is feasible. So I think we have 1,200 or 1,400 people over the age of 50. So maybe that's not the initial starting point. As we were trying this out, we initially started with 60 and older because that what felt like a more manageable number. And, I think there's different ways you can do it. Some that we're kind of revisiting, you can, if you have, like we were on Epic, you have My Chart, can you send out questions? But yeah, we were working on having nursing visits in between. The nurses could do everything. I mean, I've had at points too, I've also, my medical assistant did the MoCAs. So it does not have to be a physician or a nurse practitioner doing all of these. Our social workers sometimes do MoCAs as well, or will in their visit address some of the concerns or ask about some of these issues. And for every new patient that comes to our geriatric clinic, They also meet with our pharmacists, but our pharmacists will follow up in between, and they will also just meet with people separately about medications. And we've done in the past too, if someone's on like 10 or more or 20 or more medications, which actually is unfortunately fairly common, starting with like a arbitrary number and having those people have dedicated pharmacy visits. So yeah, absolutely. And I do think if you're in a Ryan White funded clinic like I work in, it already has wraparound services and kind of this tradition of team-based care. And so I think it's very adaptable to trying to do some of these assessments.
Great, thank you. We do have a question in the chat from Cindy Caldwell in Billings. What is being done to help people retiring to help them pay for HIV meds? They're finding that meds that are newer have high copays, and they're having to prescribe meds that are not as new or getting meds that are manufactured in another country. So I guess that transition from employed patient to being on Medicare Part D.
Oh, so I was just going to say, so ART is still a protected class of medications in Medicare Part D, meaning that you should not have to switch because of copay. So I'm actually a little surprised to hear this. That is not something that we have encountered. And there was a lot of advocacy that went into making sure ART stayed as a protected class. Other examples are certain immunosuppressants and chemotherapy drugs. I'm wondering, I don't have a great answer for that. I will reach out to one of my pharmacy colleagues. And if you want to email me, let me see if I can access the chat. Because I would be curious to hear more, because my understanding is that with it being a protected class of drugs, patients should not be experiencing that on Medicare. So this is actually really important. So if you can send me an email.
Thanks. I think we have found that in San Francisco, the coverage is a little bit different than in other parts of the country in terms of ART coverage in particular. You have a very robust coverage program that I don't think is consistent across other areas, cities or states. So that might be a difference. But yeah, for Medicare plans, I don't think we have the same. We don't have the same kind of coverage in Washington State either that you do.
Okay, so maybe it's, yeah, this would be actually, now might be a time to say this is, I will actually be leaving San Francisco at the end of the month and moving back to the Midwest to be closer to family. And yeah, so please email me with some of these examples, because yeah, yes, I absolutely agree with you that San Francisco has different resources. But I am surprised with it being a protected class that this is coming up so often, and it may be with the Part D plans offered, but again, that the protected class is supposed to supersede that on a federal level. So so I think this is something that maybe we need to think about at a national level.
Thank you. Are there any other questions for Dr. Green? If not, there's her email there. You can follow up with her later, but this is really, really helpful. And thank you so much for presenting this super practical, informative talk.
Yeah, thank you all. And thanks for inviting me today.
All right, everyone, have a great rest of the day.